Welcome to the Therapist Thrival Guide. My name is Miranda. I'm a licensed clinical social worker here at Ellie Mental Health, and I'm here with Rachel Snipes. Rachel, would you go ahead and introduce yourself?
Hi, Rachel Snipes. I'm in the Columbus, Georgia clinic. I'm a licensed professional counselor. I have a couple of certifications in supervision and trauma. Do quite a bit of work in trauma, specifically around the areas of sexual assault and domestic violence. But I also do a good bit of work with our topic today, which is bipolar.
Bipolar disorder. This is not a topic that we have touched yet, so I'm so excited to have you on here. I'm really grateful for you stepping outside of your comfort zone and talking about this with me. And I was telling Rachel before we started recording, this is something that I feel like I have not worked with someone with bipolar disorder. I'm not super seasoned clinician yet. I'm still learning, and so I'm really excited for this conversation and trying to learn more about this important topic. So let's dive into kind of like symptoms. How would you define bipolar disorder? What are some how do we define this?
I think it's really important because there's so many, I use the word myths, I guess. Actually, no, a better term is misinformation about bipolar and what it looks like. And um, how it actually shows up in your office can look a little bit different from the actual DSM criteria. Um, but on a very basic level, it is about some extreme highs, extreme lows, but there's also like it's not really a middle ground, but kind of a milder high and a milder low with the hypomania. Um, and I think a lot of people think of it as somebody that's feeling great all the time and doing all these wonderful, extravagant things. The part that's missing is that's not always controllable. It's not always as great as it seems for the person that's experiencing that. And sometimes it's not fun, extravagant stuff. Sometimes it's irritability, extreme irritability, which is no fun. No fun for that client, that person experiencing it, and no fun for the people around them.
So when we're talking about bipolar disorder, there's really two types. There's bipolar 1, bipolar 2. What are the differences between these two types?
The biggest difference, I think, is whether or not with bipolar 1, most people will experience a depressive episode, but they don't have to. With bipolar 2, that's probably going to be the first thing they experience. Because with bipolar 2, that's when that hypomania can come into play. And that is, don't always feel bad.
Could you define what hypomania is?
Um, hypomania is, it's a little bit of a high, but it doesn't disrupt the day. It doesn't disrupt the functioning of the person that's experiencing it. So there might be increased activity, increased energy, might be decreased sleep, but it's still not disrupting daily functioning. You may have somebody that talks really, 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 really fast, or they talk a lot and you can't get a word in. And this is not like just somebody who you can't get off the phone or something like that. This is like you cannot get in. So it might be a little bit unpleasant for other people as well, but not disrupting. A lot of times, what I have seen with bipolar 2 is people coming when they're depressed. That's when you see them because the hypomania for them is not disrupting. It's not causing major problems for them. It's the depression that is like, okay, what's happening? I don't like this. What's going on? If they recognize it.
So I'm just trying to think through, like, for a lot of our clients who are eventually diagnosed with bipolar disorder, specifically 2, they might come in and initially be diagnosed with depression because that's kind of like they're thinking this is the problem. And and so that's what they're coming in for.
So with all of them, actually, one or two, you can have a different diagnosis initially. Sometimes with your bipolar 1, you might have a diagnosis in the anxiety family, or the stressor family, I guess is a better way to say that. But identifying the patterns, and so a really good history is helpful with diagnosing. Looking for those patterns and those triggers and things like that is very helpful. But yes, sometimes people get a different diagnosis. ADHD sometimes is another one. And it's not that that's not there, but sometimes those are the symptoms that are readily seen because you don't
Sure.
see you don't have that history or see those patterns, and they may not be in a full-blown manic episode. In fact, you may not see them during a full-blown manic episode. Um, so you wouldn't have that knowledge. So now back again to a good history, good psychosocial assessment is very helpful with that. So yeah, a lot of times people can go a very long time saying, I've been diagnosed with anxiety, I've been diagnosed with ADHD. And it's not until later that it's like, okay, we have this diagnosis of bipolar because now we're starting to see some patterns.
Sure. So they might have different diagnoses for a long period of time, but then it's not until you really see those patterns that you can start identifying.
Part of that is if I see different therapists. So if we're not consistent in our therapy and don't work with someone long enough, I may not, as that therapist, pick up on that because life happens for whatever reason, and you stop seeing me. You start seeing somebody else. Well, when you see them, you present in a different way. So you can have a person who shows up with you and says, hey, I've been diagnosed with this, and this.
Yeah. So when we're talking about like a really thorough history, what are some questions that you're asking to try to like suss out or see some of those patterns?
I can only talk about me. When I'm assessing during those first initial sessions, and you tell me that you experience anxiety or depression, I need you to tell me what that's looking like. So I don't just accept, yeah, I have anxiety. Okay, tell me what that looks like. And depending on how the client answers, I ask more questions to see about that. I also ask questions like, well, if they explain that something has happened, so you ask about hospitalizations and you ask about behaviors and different things like that. And so if something stands out, then I wanted to know if they thought that was unusual for them. Did other people, family members, friends, tell them or imply that that was also unusual behavior for them, which is another very good point. I'm jumping a little bit, but when we're looking at all of these behaviors, it is about what's unusual for the individual, what's outside of their norm when we're talking about like extreme stuff. So if we're talking about risky behavior, what's risky for that person? If you have somebody that just likes extreme sports, then we can't just say, well, they go skiing all the time.
Right.
Okay, well,
Manic episode. I'm just kidding. Because when you're asking about depression and anxiety, I mean, we know what depression looks like. We know what this looks like, but talk to me more about like mania. Does mania sometimes mask itself as anxiety? And that's kind of where you're going with that? Or what does mania really look like in real life?
So I think it depends on where you see the client.
Like where in the cycle? Okay.
There are some you're not going to see. If it is truly, truly, truly severe and you're looking at hospitalization, then you're going to see some really extreme behavior that's going to get them put in the hospital. One of the things, and this is where not just the individualization comes in, but also culture. Because I've had some of my clients with bipolar say, this is how I have been my entire life. Nobody has said this was a problem. Yes, people tell me I talk too much. But not that my talking too much was a problem. Or everybody in my family talks fast. So what? Everybody is loud. Every, a lot of people talk with their hands. There is a degree of that where that is normal. I talk with my hands. But it's another thing if I'm talking with my hands and I stand up and I start doing stuff and showing you, acting in a place that's not appropriate for. So again, we're talking about stuff that's outside of the norm for the individual, and I think looking at making sure we have those cultural considerations in mind plays a big part. That also can keep people from coming in because that's normal. That's normal. And so why would I come in? Because nobody's ever told me it's a problem.
Right. And I feel great.
Right. And I feel good. But then I can come back and say, well, you've had 6 jobs over the past 9 months or so. What's going on with that? Let's talk a little bit about that. So there are some other things there. And again, back to the history. And some stuff, even with a good history, you still won't find out until over time. Ideally, when we talk about a holistic approach and bringing in family members and who can also share information, that can be helpful for them to share what they could have seen. In my experience, I don't get that very often. There may be clinicians who do, but where I am, I'm not bringing nobody in. They don't need to be And honestly, sometimes I'm just happy to have the client in front of me. We minimize, I think, maybe not minimize. I think sometimes we don't even think about what it takes for a person to come in for therapy in the first place. Like we are still fighting the mental health stigma. Have we come a long way? Yes. Do we still have to fight? Yes. We still have to fight. And so if I just got you, let me work with you.
Yeah.
If we can get somebody else in here, that's great. But if not, okay, let me work with what I got. So sometimes it can take a little while to identify some of those patterns and some of those behaviors. But starting off asking some of those questions, getting beyond the surface level and the basics of the questions. Sometimes, especially when we have an EHR, because we're beyond paper, although I still love paper. That also speaks to how long I've been in the field. Okay, sorry. It's easy to check a box and just kind of move on.
Yep.
Especially during the intake, because everybody don't have 2 hours to do an intake. Most of the time, we still got the same 50 minutes that we have for a regular follow-up session. And so if I'm just checking off symptoms and not going a little bit further, a little bit more in depth with it, I may not get a good understanding of what that looks like for you to help me, do some assessing on that.
No, that makes a lot of sense. And I want to kind of return back to the symptoms. I think that when I think of mania or like a manic episode, my thoughts go to feeling really great, having tons and tons of energy, not sleeping. What else am I missing? What are other parts that go into a manic episode?
So those things are there. The increased activity, okay, and the increased energy. Let's use those 2 examples. So I have that, yet I'm not finishing a thing. I'm not completing the task. So I've started 5 projects. None of them are completed. And I have 5 more ideas to do.
And impulsivity is a big part of this too for a lot of people, right? Is risky behavior always included in this too, or not necessarily?
The impulsivity and the risky behaviors, yes, can go together. I'm sorry, can be separate. You may have one or the other. Maybe there's the impulsivity, and again, I think culture plays a part in this too, of what the impulsivity looks like for the individual, what the risky behaviors look like for the individual. I've had clients who their risky behavior was sex. So they have multiple sex partners. They're having sex all the time, which is outside of their norm, where they would just be in one relationship and you know, it's not always I spent all my money and now I can't pay my bills. You know, I go out and if I want it, I see it, I buy it. It's not always that. But it's also not always like bungee jumping. It may not be all of that.
Sure.
So considering the person, what is that?
Hmm.
I had a client who a lot of times really quickly gets through the feel good part of it and gets to the irritability. Well, now I want to curse out everybody or I want to fight. That's impulsive. That's risky. There's consequences. What are the consequences that's going to cause you problems? So we're back to, the disruption piece with this mania. How is it disrupting your functioning? Can you get through a day without a problem? Can you get through a day where you've completed a task, like followed it all the way through? Um, do you have to have somebody with you? And I don't mean like supervision, but like, hey, remember I asked you for this? Did you get that? Oh, yeah, I got it. I'm gonna bring it to you in 5 more minutes. Okay. A couple of hours go by and hey, what happened? Oh, I was on my way, got distracted, and
Yeah.
and so that's a part of it as well.
I think one of the reasons why I struggle with this diagnosis is it feels like it could be so many different diagnoses. Like, I mean, even just as we're talking, my brain is going through the differential diagnosis and I'm like, yeah, I can see why this would present as ADHD. I could see why
Mm-hmm.
this could present as borderline personality disorder. I could see why this could present as depression, PTSD. I mean, it feels like it's so hard to really pinpoint unless you really do have that stellar history where you can see that pattern. But I mean, I see clients who have ADHD and they're impulsive or they can't finish tasks or
Mm-hmm.
they're irritability or they're irritable. Um, and so I think that I struggle a little bit with this because it's like I have a client who has ADHD and depression and I feel like sometimes she kind of fights between, the ADHD is more prevalent right now. And so then it's making me
Yeah.
think, oh my gosh, could she have bipolar disorder? I think that this is where, and I will say too, bipolar disorder feels like a really heavy diagnosis too. And so I think that it feels easier to me to diagnose. I'm not saying that this is
Yeah.
best practice, but
Yeah.
because it's not. But in some ways it feels easier to say you have depression
Mhm.
but I know that there are issues with that too because you're not getting the right treatment then. You're not getting the full picture. Can you tell me a little bit more about why it's so important to have a specific bipolar disorder diagnosis instead of kind of skirting around with these other ones?
You hit it right on the head, and that's the treatment part of it. Bipolar is a not and to your point, not to minimize other diagnoses or mental health issues, but it does feel really heavy, and it's because it's chronic. And without the proper diagnosis, there's no proper treatment of it, and it can get so disruptive to um, and lead to multiple hospitalizations. Well, that has a variety of effects on the client and others as well. It's also difficult. You hit on several things that make it challenging to not only just diagnose it but deal with it and even treat it. The labeling, the labeling of it. I don't want to be labeled with that, or I don't want to be the one to label you with that. Particularly the younger, we're talking about. So that's a big deal. And then, like I mentioned earlier, have I spent enough time with you to give you that diagnosis? If I started seeing you during the summer. And in the fall, you decided you was going back to school. You kind of drop off because you're busy with school. Maybe that's how I'm looking at it. I don't know that that might be part of your mania if I haven't worked with you long enough. That impulsivity was one night I just decided I'm going back to school. I done signed up. I got 3 classes. If I don't have enough time with you, if I don't have enough history, I may not know. And so then by the time you come back to me, I'm still just thinking maybe you went off and stuff. So how's school going? Oh, that didn't work out. I lost my financial aid and then I couldn't go back. Well, there's still a chunk missing in order for me to diagnose it as bipolar with just that little bit of information. If I don't do the ask all the questions and get some more history and stuff. So it's a big challenge. There's a lot of things that I think that can contribute to that when we look at why people aren't consistent with therapy. That's going to make it difficult, I think, to diagnose that. And even if I can diagnose it right off the bat with a very good history, am I going to be able to treat it successfully if you're not consistent, if you don't believe you have it? I've had clients, whether it was me diagnosing them or the psychiatrist, to say they didn't like that diagnosis and they didn't believe they had that. And I literally had a client one time to tell me that I needed to write a letter. I needed to call the psychiatrist and tell them that I didn't have that. They did not have the diagnosis that they gave them. They had what I had diagnosed them with. But I'm not doing that. I'm not doing that. And so we had to have this whole conversation about how you can get different diagnoses, this, that, and the other, and all that kind of stuff. It didn't matter. She was mad. And I wanted to say, this proves that the doctor was right. But, you can't say that.
So talk to me about, how do you treat bipolar disorder? When you diagnose someone with bipolar disorder, what are some of the main approaches or treatments that that you would recommend or that you do with clients?
Having a good diagnosis is the first thing. Medication management is very helpful. Therapy is also very helpful, and education. To get compliance, we need people to accept that they have that, and then learn about it so that they can be in compliance with the regimen that is going to be helpful to them. We have some additional challenges with that. Getting on the right medication, which means you got to work with the psychiatrist, and you can't just quit taking medicine, and you can't just be like, I'm tired of this, da, da, da. And we get that on the regular with other stuff where I'm not going to take no medicine. I'm just not doing that. Or I took the medicine for 2 days. It made me sick. I'm not going back. I'm not doing that again. That's day to day. So we have to have that. The education, I think, is also important, not just for the client, but the people in their circle. How do we learn about this diagnosis so we can be supportive of the client as they get stable? And how can we help maintain that stability? And stress can be a huge trigger for some episodes, right? So we have to consider some of those environmental factors that someone who maybe isn't stable, how does that impact their mania? How does that impact their depression if they're having a depressive episode? And so who is in my support circle to help me or support me with being healthy, using healthy coping skills? A lot of times in a manic episode, the client might not even recognize they're in a manic episode, and especially if we don't have the education on board to even know what the signs and symptoms are for me as that individual. And so if I have an educated and supportive circle, they may be able to help me with that and keep things from getting, leading to like hospitalization or worse. Because sometimes in a depressive episode, we can get the increase of suicidal ideation.
Okay, that makes sense. And I was just going to ask you, like, when people are hospitalized, this might be a stupid question. When people are hospitalized for bipolar disorder, is it always because of suicidality, or are there other reasons why people might be
Yeah, it could be other reasons.
hospitalized?
It's not always suicide. It could be other reasons. It could be some extreme behavior got them in
Mm,
trouble, but uh, this is probably not going to be popular. But I have had experience where we've had people to get in trouble legally, and
oh,
then
sure.
it is determined, okay, we got a mental health episode here, so then they're
That's a good
transported to
point.
the hospital, that
Hmm.
kind of
Yeah, no, I think that makes a lot of sense.
thing.
I'm just thinking through, like, as you were talking about medications and treatment options, I was just thinking through how I know you're not a medication provider, but I would imagine that normal SSRIs or antidepressants don't work as well for people who have bipolar disorder. I know that I've heard of people with bipolar disorder being on like antipsychotics or other types of mood stabilizers. Curious kind of what you've seen with your clients.
I've seen it depends on the person, and what they respond well to.
Hmm.
And unfortunately, sometimes you can get to a point where there is some psychosis involved.
Okay, that makes
Um,
sense.
so they may be put on an antipsychotic, but also now, you know, off label, off shelf use, whatever you call that, when we find out that this medicine works really good with this thing. So it's very individualized treatment, which is why the consistency and the communication is really important. Keeping those appointments. Here's what I've seen. Here's what I've noticed. And being honest about that. Um, and establishing some really good rapport with your clients, whether it's the therapist or the psychiatrist, either way, so that we can ask those difficult questions and do some very gentle, compassionate confrontation or challenging, to find out what's really going on. Um, but it's tough to do all of those things. It can be hard to get someone to agree to take medication or keep it up because of the cost. It can be hard if someone says that they don't have the support, um, of others. They're not in a healthy environment, even though they're trying to get healthy and stable. They're still in a chaotic or unhealthy environment. So that can keep them in limbo as well.
Gosh,
Maybe
and
I can.
Rachel, what you were just saying about like the medication also made me think of how, like, for people who are in a manic episode, it's probably so easy for them to be like, I don't need medication.
Oh,
I'm not gonna,
I'm sorry.
like, that's probably such a common issue. I didn't even think about that. That makes
All the
sense.
time. I don't need
Yeah.
this.
Hmm.
I don't need this.
I feel great.
Why am I taking it?
Interesting.
Or
Yeah.
just forget. Just
Mm,
simply forget.
yes.
Um, because I'm not thinking about. I
Hmm.
feel good. I'm off my routine. Remember, I get easily distracted. I have all these other great ideas in my head,
Mm.
and I've started them. Where's medication? What is that? So
Makes so
yeah.
much sense. Yeah. The other thing I was going to ask you is, so let's talk a little bit more about um, therapy treatment, like therapeutic treatment. You talked about kind of lowering stress levels, um, environmental things that can affect someone's cycles or cycling. What are some other ways or things that you do in session with them? Is there like a specific modality that people would recommend for those with bipolar disorder, or is it more so like, treating a depressive episode much like you would depression? Like, what does this look like in the therapy sessions?
My therapeutic approach, my go-to is CBT. I do, incorporate other stuff, solution focus, DBT, things like that. Um, for me, the education is key. So let's talk about what it is, how it shows up. Let's figure out what the triggers are. What are your signs and symptoms? All that's going to be, different for every client. That's one of the first things. The next thing that is huge for me with my work is routines. Let's get some routine. Your whole day don't have to be a routine, but we do need maybe a morning and an evening routines. We got to have something in there that is consistent, that even if, for me, it's a morning and a night routine, that even in the middle of the day, if I start getting a little off, hopefully when I get to my nighttime routine, that can have me settle down, reflect, check some things to make sure I'm okay. Am I starting to get off? Because I now know what my triggers and signs and things are. Did I have any of that today? Am I dealing with a situation that's more stressful than norm? Did my workload just drastically increase? Like, I think having those things in place for me with my work with clients has been very, very helpful. That also helps me to be able to identify patterns, or if we're getting off, if the client does it, because I can check in on those things. Okay, wait. So I'm missing something because I didn't hear this, that you did this part in your routine. And we can consider things that will throw us off of our routine that's regular for anybody else. Oh, well, we went on vacation. Okay, great. Now when we get back on it? When we get back on it. So those are two staples that are very helpful for me, that in my work, I'm doing those things. Now I would tell you it's not easy. It's not easy. If I have a client who doesn't even buy into the fact that that is their diagnosis in the first place, we got a lot of work to do. I can't get to the rest of it.
Yeah.
If we have someone that's not consistent with the routine, or they say they can't find one that works for them, or they just don't want to, they get discouraged about it, or if we get a manic episode in the midst of all that. So it's a lot of work, and you will find people, oh no, I don't want to work. There, clinicians who say, no, I don't do that. I don't work with bipolar people. That's too much. Oh, they got anxiety. Okay, I can work with the anxiety. I can work with anxiety. Or they're depressed. I can work with the depression, but I can't do the bipolar. It is hard. It's hard. And I think I'm saying it's hard. It's hard even as a person who does it. Not that other mental health concerns are not, but this is one of the ones that is quite challenging for all the reasons we've already stated before. It can be hard to pick it up in the first place, for all the reasons we said before. And then even once we do, it can be hard to just be stable enough to get to treatment and get that treatment in and working and be consistent with it.
So what draws you to this group? What draws you to people who have bipolar disorder? Because this is something you're passionate about, and what draws you to it?
I don't have an answer other than I like for people to be, and I say this all the time, when we get people, sometimes people walk in to schedule appointments, so they're not necessarily my client, but when I'm working with clients, or talking even to some of the other providers, we just want people to be healthy. Whatever that I may not be the one to help you get there. That's okay. There's no judgment. Nobody's mad. What does it take for you to be healthy? And I know, because I have been in the field for a while. I know, and I think we all say we know, but like, I really know the gaps that are in our community and the limitations that clients can have to access to resources and healthcare. And culturally how sometimes our mindsets and our traditions and our belief systems just don't let us get there, and it is hurting us. So I, because I want people to be healthy, I want to be able to identify some of those hurdles. Let's talk about them. Let's get educated about them accurately, factually, and let's figure out how we can move forward in, just addressing some of those challenges and concerns that people have, because we don't have to live like that. We don't have to.
Right, right. Okay, selfishly, I want to pull on your like clinical experience and when you are working with a client who you believe has bipolar disorder, how does the conversation go when you first diagnose them? Because I think that I get intimidated by like slapping these huge diagnoses on people sometimes. And bipolar disorder isn't even necessarily one of the scariest ones. Like I'm putting
Right.
that in quotation marks. But like, um, I'm just thinking through how do we say this in a way that's compassionate, not scary, normalizing and also normalizing the fact that like this is going to be kind of it might be scary for the client to
Yes.
hear. It also might be very relieving for them to hear, but how does that conversation go? How do you do it compassionately?
I think one of the challenges too is a lot of times now, because we have the internet doctor that says,
Yes.
I have
Yes.
this. And so clients come in saying, well, I already know I have anxiety. I already know I have depression. Okay, well, how do you know that? So when I'm coming to you with, here's what I see, I'm challenging what you think you have. On top of it's just already a difficult conversation to have. Typically I start off with how we got here. So what brought you here, how we have been doing the work that we've been doing, and my observations. And then, hey, sometimes I can just have that conversation of that looks like this, that meets the criteria for this. Sometimes let's look at it together. And you tell me.
Sometimes in session you'll just pull out your DSM and you'll say, let's walk through this and you tell me if this feels like you sort of thing.
Yes, and that's just not for this. That's part of my personality and my work. I am notorious for saying, "Pull your phone out, look this up," you know, in a session. So, yes, if we need to walk through it, then that's what we do. The other thing that I will do sometimes is say, "This is what this looks like to me," but you know what? Maybe we need some additional support, another set of eyes. What if we get an evaluation? So that way they can go through, whether it's a psychiatrist, psychologist, whichever one they choose. We talk about the differences. Of course, I'm gonna be opting for the psychiatrist because if I already know you got bipolar, I know you need medicine. But we talk about that, what that looks like. And so then when they come back with that diagnosis, now let's go through this again. Again. And you're right. Sometimes people are relieved. I have seen that. Okay, I knew something was going on, so I'm not crazy, right? No, you were never crazy. But I've also had people to be very angry and completely deny that that's what they had, even beyond me, right? Even with the diagnosis from the doctor. And no, I'm not going to take this medication because I looked this medication up, and this medication is for this. It's also for this. So, uh, and sometimes I've had people to not return. Um, Fortunately, for me, um, with good rapport, we can work through that. And it's okay to not like it. It's okay to be angry.
Right.
It's okay if you need to sit with it for a couple of days and we
Mm-hmm.
talk about it again later. All of that is okay with me as a clinician.
Mm-hmm.
I got, I say this even though I got all the time in the world. That's why I tell class. I got all the time in the world.
Mm-hmm.
It takes however long it takes. Yeah, but I'm not worried about insurance. I'm not worried about EAP. I'm not worried about a referral. I got all the time in the world. We'll make it work.
Mm-hmm.
Um, so that's my way of just not pushing it onto people,
Yeah.
kind of introducing it, and let's see what needs to happen next, depending on the individual. Are you the one that needs to sit with it? Are you the one that needs more information? Are you the one that we need to walk through it together? Are you the one that needs to be angry for a little while? And I'm okay with that. Yes, you can be mad. Okay, you mad? You walking out? You leaving? Okay, all right. I'm calling you tomorrow, though. Okay, all right, now. And I'm calling tomorrow.
Mm-hmm.
Hey, I'm just calling to check in, and I have been hung up on. I have been told, why are you calling my phone? I told you blah blah blah. I said I was gonna call you and check in. I'm just keeping up my end of it. It's okay if you want to talk. Okay, all right. And I find that if we can do some of those things when that person's ready, they'll return. I mean, it might be the next session because we already got an appointment, or it might be a callback later when I'm in another depressive episode or something.
Sure. Yeah.
There are instances where it may take months, sometimes years, for that person because again we're back to that inconsistency. Even though I'm mad about it, I don't like it, and I don't think I have it. All I have is depression, and I just need you to help me with this depression.
Fix this.
Right. Because when I feel good, I'm not coming to you anyway.
Mm-hmm. No, that makes a lot of sense. And I appreciate how you approach that. And I knew you'd have a good response to that. I knew that was going to be great. Okay, I know that we barely touched the surface of this diagnosis. We barely touched the surface of this treatment, but I am so appreciative of you coming on here and talking through your experience and what this really looks like in clients, because I think that we can pull out a DSM, and obviously there are times where that's helpful. Lots and lots of times where that's helpful, but there's also times where it's hard to fit people within the pages of the DSM, and you're trying to see how this really looks and plays out on your couch. And so I appreciate you walking through this and talking through this. Are there any other points that you were really hoping to make in this podcast episode that you feel like we didn't get to?
I think just the biggest thing, we do need the DSM, and sometimes we have to use that as a guide. I think one of the biggest and of course, this is the message for all of our work, is deal with who's in front of you, and kind of adjust around that so that one, you build that rapport that is necessary for some of these heavier, more chronic illnesses. And when it's time to have those conversations about whether it's the diagnosis or treatment or whatever, it's a little bit easier because we have that rapport and that trust. Meeting people where they are and considering that there might be an alternative, that it might not show up exactly as the DSM says, that it might not show up despite the experiences I have had. There is still a chance that somebody's going to come in with something I haven't seen, and it still can be bipolar. And that it's okay if I didn't get somebody's not going to like this. It's okay if I didn't get the diagnosis right the first time. I'm not doing harm.
No, I agree with you. Mm-hmm.
Right? So I can take my time as long as the client is willing to work with me. I can take my time and we can work through this together to get you the proper treatment. I'm not doing harm. I'm still giving you coping skills to manage symptoms that are coming up until we can get it all right. Yeah. So don't feel rushed or that this is the diagnosis that's got to stick forever. Oh God, I gave you ADHD, and now I'm realizing after 6 months, it's not really ADHD. How am I going to tell them that? Blah 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 blah. Tell them. Look, we've been working off this treatment plan, but because one, we should be regularly talking about progress and all that kind of stuff. Anyway, I think we need a shift. I think we need to make a shift. I've noticed some things. Let me share with you what I've noticed and get your feedback and tell me what you think.
Yeah. Perfect. I mean, that's a great opportunity to shift. And you're already doing an evaluation of goals, progress, and it makes sense to be shifting and saying, where do you feel like you're at with this? These are some things that I've noticed
Mhm.
since we've been working together. And no, that's an excellent point.
Yeah.
Well, thank you so much again, Rachel. This has been really, really wonderful. I'm so appreciative of you coming on here. And
Thank you for making this easier for me because I told you I was
good.
very nervous.
No, you did great. This was great. And thank you so much to everybody who's listening. Thank you for joining and being along for the ride. I hope that this was a helpful episode for you. And if there are more episode topics that you want us to cover, please, please, please let me know. My email is creative@limentalhealth.com, and I am all ears, always looking for suggestions. But thank you so much for joining, and we'll see you
Thank you
next
for
week.
having me. I really appreciate the opportunity.